All right, let's get started. I'd like to introduce Dr. Mayer. He's the founding medical research director of Fenway Health and created a community health research program that has developed an international reputation for its capacity to conduct community-based research, focusing on sexual and gender minority health and biobehavioral approaches to HIV and STI prevention. He is a professor of medicine at Harvard Medical School, a professor in global health and population at the Harvard T.H. Chan School of Public Health, and attending physician at Beth Israel Deaconess Medical Center. Since 1994, he has served as a site principal investigator for the NIH-funded clinical trials unit, focusing on biobehavioral HIV prevention research, and is a member of the scientific leadership of several NIH-funded consortia. So please join me in welcoming Dr. Mayer.
Thank you. I want to thank you, Natan, and colleagues for the invitation to be here with you today. And it's kind of a daunting challenge to talk to this group because you span so many different disciplines. So trying to think about a little bit about greatest hits and something for everybody that might be cohesive around the theme of population health research. Okay, let's see if we can advance. Okay. It did it okay before. So there are a couple themes for my talk today, and I really want to leave enough time for the discussion. So one is this issue of community health centers, because here we are in the middle of the Longwood area. Why do we need to be thinking about community health centers and population health? Well, at this point in time, over 10% of Americans receive their health care at community health centers. And the numbers can vary because some people are frequent flyers and go to several health institutions. So if you say just having had contact with a community health center in the last 3 years, it's 50 million people. But if you say more stringently, people who are currently enrolled in a community health center, it's still more than 10% of the US population. And community health centers tend to care for patients who are economically challenged, primarily from communities of color here in the United States, where we know there may be disproportionate burden of various different diseases and infections. And community health centers, they get federal dollars to focus on providing improved health for their neighborhoods, but sometimes geographies are more widespread because certain community health centers have specialization for specific populations. So Fenway historically has focused on sexual and gender minority populations, but another example is South Coast Community Health Center, which initially was started in Chinatown, but now has offices in Quincy and several other jurisdictions and focuses on the healthcare needs of Asian Pacific Islander populations. And in certain parts of the country, particularly in the West, the community health center may be the only place that's providing care for tens and hundreds of miles. So quite a wide geography. So it's going to be fussy today. It's the typical thing that when we did it, before you all came in, it was advancing very quickly and smoothly.
That is not cool. Oh, we're drawing.
Okay.
What?
I think that's drawing.
What happened?
I don't know how you can get out of that.
Hit the red X on the left.
Oh, I see. Okay.
Okay, now try. You may have to click once to then advance.
There we go.
Okay, perfect.
All right. Anyway, so the specific community health center I want to talk about today is Fenway Health. So it was founded in 1971 by community activists in the Fenway neighborhood, actually initially closer to Symphony Hall. Current location is 1340 Boylston Street, so 10-15-minute walk from here. Initially, it was a drop-in center. It provided blood pressure checks, STI screening, and then over the years developed, had a permanent space and sort of developed more into a freestanding health center, but really very modest beginnings over the years. And for me and for Fenway, the nodal point was the onset of the AIDS epidemic, because by the early 80s, Fenway was providing STI screening on a drop-in basis for the community and had a focus on sexual gender minority health. So it was kind of a natural place to be kind of ground zero for the beginning of the AIDS epidemic. In terms of what Fenway looks like today, if you look at the patient population, primarily white population, but given the demographics of the neighborhood, it still has a fair representation of people from communities of color. About 2/3 of the patients do not identify as cisgender heterosexual. That means that 1/3 do, and health center that has more than 30,000 people who access services there, with about 28,000 getting their primary care at Fenway. That means that for research purpose, we've been able to do studies of doing case control studies comparing different populations, whether they're sexual, majority, minority, cisgender, or transgender over the years. About 2,400 people living with HIV access some services at Fenway. We've had more than 5,000 people initiate antiretroviral pre-exposure prophylaxis. There are close to 4,000 people who are still active users at this point in time. And there are also specialized services for youth, senior citizens, and their family planning. And you can see sort of the heat map and geography, mainly in the local area, but at least 1/3 of people come from zip codes that are not immediately adjacent to the Fenway area. And because it's Massachusetts, the majority of patients have private insurance, which is atypical for many community health centers. But Fenway itself is kind of a complex entity. So it's really helpful to think of it as 3 organizations and under one umbrella. There's the health center itself, which provides primary care, behavioral health services, dental services, dentistry, optometry, and has an on-site laboratory. So really a comprehensive primary care center. The part that I'm involved in is the Fenway Institute, which has components that focus on research, training and education, and policy issues. And then we have a public health program. So there's walk-in STI screening. There are harm reduction services that includes syringe exchange and community outreach programs. We have a center in Cambridge that Fenway staffs that does street medicine as well. And there's been housing and legal case management services. And just to give you an example of sexually transmitted infections, you can see that it maps throughout the organization where there's primary care that integrates sexual health as part of the provision of primary care. We do a fair amount of research around sexually transmitted infections, prevention and treatment. And then we have these dedicated public health programs that do outreach around sexually transmitted infections. So sometimes hard for people to wrap their heads around, but I'd like to say that what I do at Fenway is similar to running a small academic unit in a busy clinical entity. It's just a small but very busy clinical entity. And then some of our outreach are our public health programs. So in terms of my own history with Fenway, in 1980, I started infectious disease fellowship at Brigham and Women's Hospital. I was lab focused in studying antibiotic resistance, looking at plasmids. But I also wanted to do community service. So I approached Fenway about setting up an STI drop-in program where I'd be available at least half day a week. And they agreed to that. I also said to them, we really should be doing research because there's not a lot known at the time about the healthcare needs of sexual and gender minority populations. The leadership said, we don't do research. We've had bad relations with all the teaching hospitals that want to come in and get specimens. So we don't really think we need to do that. So that was 1980. Within a year, we started seeing some of the first people with AIDS in New England. At that point, they said, yeah, doing research makes sense. So through some shoestring grants, I was able to start collecting blood and taking histories because it was clear we didn't know what the etiologic agent was. We didn't know what was constituted risk. And I was particularly focused on people who were not sick, but who might become sick. And Jerome Grootman, who's a hematologist oncologist, BIDMC at the time, the New England Deaconess Medical Center, came back from a meeting in 1983 and said, I talked to Robert Gallo and he might have the etiologic agent. And you have all these specimens from people who are not sick. And I'm seeing all these patients who are sick with Kaposi sarcoma and lymphomas. Let's send a blinded panel to him. And we did. And we found that everybody who was sick had antibodies to HTLV3, but only 21%, or as many as 21% of the people who were asymptomatic, but engaging in behaviors that we thought were associated with risk, had antibodies. And so for the next few years, the question was, what does it mean to have antibodies to this pathogen? And that was the beginning of our research enterprise. The other thing, once that we identified the etiologic agent, was we were able to start trying to understand what were the risks associated. And so a spin-off project was following discordant couples. By this point, we knew to call the virus HIV, and we were looking at HIV discordant couples. So with George Siege, fortunately, who's here at this institution for many years in the epidemiology department, is no longer with us, and Victor de Grotola, who some of you may know, who's a biostatistician. George and Victor and I interviewed the HIV discordant couples and followed people and saw if some of the partners became infected, we're able to look over time what behaviors people engage in. But this also gave us the ability to look at what was the efficiency of anal intercourse. And so in this slide that has the various efficiencies in HIV transmission, reference number 3 was our paper several decades ago that is now sort of the benchmark for what we think about the high efficiency of anal intercourse. So this sort of gave us an infrastructure for doing research and dealing with this really horrific epidemic in the early days where we had no ability to treat individuals. If we fast forward to today, more than 2,200 clients getting their primary care and a couple hundred getting other services at Fenway are people with HIV, mainly men who have sex with men, and about a third are communities of color. About half are below 200% of the federal poverty limit. Majority, not majority, but substantial number publicly insured here, and even 8% uninsured. So different than the overall health center, as you can see, more health disparities for the population. But happily, the metrics in terms of linkage to care, the accessing antiretrovirals and being on and virologically suppressed are somewhat better. But the other thing that happened during these early days, and for those of you who are younger may not really appreciate the fact that you had this period from 1981 with the first recognition of the epidemic to the advent of effective triple drug combination therapy, almost a 15-year period of time. And this led to organizations like ACT UP being developed because the feeling that business as usual in the way clinical research was being conducted was just not sufficient, and that people might be dying before they had access to experimental therapies. So our own experience with this, we knew that there were physicians in San Francisco and New York that were using different ways to prevent and treat pneumocystis carinii pneumonia, at the time the most common opportunistic infection. And this actually involved setting up almost what looked like telephone booths and putting in air that was infused with pentamidine. Pentamidine is fairly toxic when given systemically, but aerosolized was reasonably well tolerated. This was an atypical approach, but we had this underground of different people working in the community saying this is what was working. We felt the need to try it, but because this was experimental, we set up our first institutional review board. This was about 1986, 87, and this was sort of launched us towards this realm of doing more clinical research, not just doing descriptive epidemiologic research. But interestingly, even though we're in a very enlightened state, Massachusetts, some of our colleagues at the teaching hospitals said, why are these people doing research in this community health center, and complained to the state health department? So we had to go and show them that everything was above board, and they approved the project and were able to continue it. But this led to our development of research. So from this beginning, so the three things really, trying to understand what was safe and not safe in terms of transmission dynamics, trying to understand the natural history, and then trying to do emergent responses to addressing the opportunistic infections. This was sort of the nucleus of what led to our research development. And so this led to what we now call the Fenway Institute. The woman in the picture here is my colleague, Judith Bradford, who unfortunately passed away a few years ago. Judith was a social epidemiologist and came to work with us to help set up a population study center, because our rationale was by 2000, medical advances were making HIV quite manageable. And we started realizing as we dug deeper, here you had these treatments, but not everybody was accessing them. Some of that had to do with resource constraints. Some of that had to do with psychosocial problems, people maybe getting prescriptions, but not being adherent to the medication. Why were they not adherent to the medication? Well, they might be depressed. They might be having issues around substance use. What were some of the reasons for those issues around substance use? You start unpacking, you realize that the internalization of societal rejection, getting adverse experiences with the healthcare system affects them. And these issues, the interplay of society leading to individual behavioral outcomes, didn't only affect HIV, and that sexual gender minority people who are not at risk for HIV, for example, lesbians also had health disparities that were very similar, high rates of depression, high rates of substance use, other healthcare issues that really required a broader frame. So we said, really, this cannot just be about a single virus or a single disease. This is really about population challenges, and that we shouldn't only look at disparities that are causing adverse outcomes. Many people in the community are also doing well. What are the reasons why people are resilient? So this led us to convince the leadership at Fenway to say, we're not asking to create a separate 501c3, but we want to really try to build a research infrastructure that not only addresses HIV AIDS epidemic, but more broadly addresses issues as to how we can improve sexual and gender minority health. So the Fenway Institute today has three buckets. There's the research and evaluation part of the health center, part of the institute. There's the education and training programming that we do, and the healthcare policy and advocacy work. And really one of the larger institutions focusing on sexual gender minority health that's based in a community health center. So just to drill down in terms of what we're doing, and then like to sort of end the talk talking about something at least near and dear to Yonatan's heart, as many others in the audience, some specific infections. But if we step back more broadly about what are the kinds of things that we focus on, certainly when I've spent a good deal of time being involved in our studies related to antiretrovirals for HIV prevention. So we were involved with the first study in men who have sex with men that led to FDA licensure. The IPREX study were one of the two sites in the United States conducting that efficacy trial that showed that TDF FDC PrEP worked. And more recently, been the only site in New England involved in the lenacapavir for a PrEP study that was published last year, but also developing a variety of evidence-based interventions for key populations such as young transgender women that are based on sound behavioral science research. The research portfolio is quite diverse. In the past, I'd say it's mainly NIH funded. In the past year, I'd have to say that has changed a lot. So we increasingly rely on studies that are supported by industry, but also some work supported by foundations. The focus also includes people who use drugs in addition to people who may be at risk for HIV or other infections through sexual contact. In addition to studying the epidemiology of STIs, we've also been involved in some STI vaccine work, herpes vaccine, GC vaccine. That's not going further any further, and also some studies of new diagnostics, point of care assays for STIs. We've had a lot of work going on in syndemics, studies of interventions for depression, substance use, and studies that involve social determinants of health. And then health informatics, which may be of interest to people here. We're involved in three networks, two funded by the NIH and one funded by PCORI, the Patient-Centered Outcomes Research Institute. The two NIH ones are focused on people living with HIV. CNIX, which is following about 50,000 people at 10 sites across the United States receiving primary care. And CNIX has a specimen repository too, which may be of interest to some individuals. And then NIH is a less granular network of networks. So that's following close to 200,000 people with HIV. That includes data from the US, from Canada, the VA system, as well as the NIH network. And then Advance is funded by PCORI, and this is a network of community health centers around the country, and it's following over 10 million individuals, not HIV or STI specific, much less granular information, but certainly a platform to do studies on population health. A colleague, Sean Kay, who has a doctorate in healthcare policy, focuses on health disparities. And basically, because we're a 501c3 in a federally qualified community health center, we can't do formal advocacy, but can do policy and information. So create issue briefs to provide for lawmakers to try to, in the past, when people at NIH were amenable to this, provide monographs to inform them about health disparities experienced by sexual minorities as well. And the funding for this is from our generous Commonwealth and from the Boston Foundation. One of the big areas for advocacy has been around sexual orientation, gender identity data collection. So 2015, there was a decision by Department of Health and Human Services that as part of meaningful use coming out of the Affordable Care Act was that all health systems should be asking patients about their sexual orientation and gender identity. There had been this myth in the past that patients would be uncomfortable if their providers asked them about their sexual orientation and gender identity. But we actually did a study published in PLOS One and working with people accessing care at 4 community health centers. 2 had a focus on sexual gender and minority populations. 2 were more general population community health centers. 1 was in the Deep South. And we found that independent of where people receive care, whether they were heterosexual, homosexual, cisgender, transgender, the vast majority of patients thought it was appropriate for their providers to ask them about their sexual orientation and gender identity. The majority of people said they thought that would be important for their health care. So we're glad to show that that's a canard. And so a lot of the advocacy work has just been to ensure that providers do ask these questions and that they know how to ask the questions. There's certain structured formats so that one can keep people as comfortable as possible, but obtain this data. And it's very important for population health because if you're not counted, you don't count. So that's been really important part of the advocacy work. And then in terms of the education and training, we've created both monographs and educational tools. We have this National Health Education Center, and currently we're still, knock on wood, funded by the Health Resource Service Administration, do trainings quite broadly. I'll show you in the next slide how wide the reach is of the center. But basically, the trainings talk about best practices. What are the different healthcare needs for the different populations? Based on different behaviors, based on different prevalences, based on different disparities. And the programs will include on-site trainings, distance learning, toolkits, and we have a website. I say knock on wood because it's a competitive renewal grant from HRSA, who knows in the current environment, but the trainings have reached the majority of states in the United States. We've partnered with the American Medical Association. We've also put out a textbook, one textbook that's more broad about sexual gender minority health, and the other that's been focused on transgender healthcare. And we've done a fair amount of training around the world. We've had collaborations with India for over 20 years, working with one grant that was recently terminated with College at Hopkins that was funded through USAID. Done work with training providers in several countries in sub-Saharan Africa. And much of this work, again, was funded by USAID, so we don't know if it's going to be going forward ever again. And work in South America through some foundation support to train Peruvian healthcare workers to provide better transgender healthcare, and some work in more resource-rich environments. And some of the funding for this training now are actually private enterprises. Certain companies want their staff trained around culturally competent care issues, and some municipalities have also paid to support this kind of training. So I want to switch gears and talk about antiretroviral prevention at very high level, but very happy to answer more specific questions. So our first formal involvement in this was we were the only site in the U.S. to pilot the study HPTN-052, which enrolled HIV discordant couples. This was before the era of treat everybody independent of CD4 count. So these were discordant couples. We enrolled same-sex discordant couples, and the study basically was the RCT that showed that early initiation of antiretroviral therapy had a major impact on the likelihood of transmission of HIV to one's partner. Certainly, there have been subsequent observational studies like the Partners study and Opposites Attract that have validated this and really have led to the mantra of U equals U. Our bigger focus has been on the use of antiretrovirals for prevention for people who are not living with HIV. So this slide sort of summarizes all the different PrEP studies that were up there. The IPREX study, and that was our initial foray. And as mentioned, we've been basically involved in all the different modalities till now. And a lot of our work now is really trying to figure out how do you improve chemoprophylaxis. And some of that involves looking at new oral drugs and strategies. So we've done some work on demand PrEP, and we were the only site in New England looking at MK-8527, which is now in the process of being evaluated in 2 efficacy trials. So MK-8527 is a non-nucleoside reverse transcription translocation inhibitor, and it is given as an oral pill once a month. And what we learned in the phase 2 study was that it's extremely well tolerated and really no significant side effects. So it'll be very exciting to see if a monthly pill will be sufficient to protect against HIV instead of asking people to take daily pills or other regimens. From the beginning, we've been involved in studies of vaginal and rectal microbicides. And although this area, there was a couple vaginal microbicide studies that were not successful, they're still interested in rectal microbicides or other rectal topical approaches because the thought is that this may lead to behaviorally congruent behavior. In other words, people who engage in anal intercourse very often may douche before sex as a perceived hygienic practice. So if you have an antiretroviral douche, that may actually way to that somebody would be doing something that they'd be doing anyway, but protecting themselves. So we actually are involved in a phase 2 study of an on-demand tenofovir rectal douche compared to oral on-demand medication. So that study is being conducted in the HIV Prevention Trials Network. We have been involved in some of the studies, the early phase studies of the intravaginal ring, enrolling cisgender female participants. A lot of work, our behavioral scientists affiliated with Fenway are doing a lot of work looking at different adherence strategies, including some really cool stuff. Peter Chai is an emergency medicine physician based at Brigham and Women's Hospital, has conducted a number of his research studies at Fenway and looking at the combination of a pill that can be over-encapsulated, have a gelatin over-encapsulation that has a sensor that when it hits stomach acid, issues a signal that can be picked up on a phone through an app that says whether the pill has been ingested or not. And the question is whether swallowing the pill and then you get a message, good, you took your pill at the right time today, or gee, hadn't taken your pill yet. So starting the beginning of this kind of research, and doing that on a daily pill doesn't make any sense. But if you start having pills that you're taking once a month, maybe having some adjunctive adherence support may be worthwhile. Again, is this going to be acceptable on a population level is a big question, but it is sort of a very interesting approach. And as mentioned, we've been involved in the injectables. We were a site for HPTN-083, which was the efficacy trial that showed that cabotegravir works, and then the Purpose 2 study looking at lenacapavir. And now we're completing a study of lenacapavir in cisgender women and starting a study of cabotegravir for PrEP for people who inject drugs at the Cambridge site. We've also worked on trying to tailor PrEP for key populations because the PrEP package may be different for different populations. So with colleagues in the HIV Prevention Trials Network, we've worked on developing a culturally tailored, client-centered care intervention focused on young Black men who have sex with men. This study was highly acceptable, and the plan was for it to be scaled up, but that has been put on hold by the current administration. And we've also been involved in studies focusing on youth through the ATN, the Adolescent Trials Network, and studies looking at PrEP, and is PrEP plus individual counseling better than group-based evidence-based intervention, EBI, for a behavioral health intervention. So these studies are still underway as well. Another area, another colleague who some of you may know, Doug Krakauer, who's based at Beth Israel Deaconess Medical Center, but spends part of his time at Fenway. Doug coined this term more than 10 years ago, the purview paradox. And that's basically this, that for PrEP, there's not like a home for PrEP naturally, because many HIV providers say, I take care of people living with HIV. I'm not taking care of people at risk for HIV. And many people who are primary care providers say, well, these are specialized drugs, so the HIV specialist should take care of them. So Doug's work with us is to try to figure out how you can use electronic health records to identify PrEP candidates. And there are things that are being collected routinely, not necessarily as part of a PrEP workup. Demographics, we know that HIV is more prevalent in specific populations. Lab results, if somebody's screened for rectal GC, that would probably be a good candidate for PrEP, one might think. Diagnoses, incident STIs, and prescriptions. So you can use this information. So Doug created an experiment where looking at the Health Maintenance Organization, Atrius, said that they had about 800,000 patients. About, at the time, 885 patients were living with HIV in their care. So, 1%. And there was a much smaller number of people receiving PrEP. So the question was, could more people benefit from PrEP? So Doug used Fenway data to develop an algorithm and then said, how does the algorithm work? And if you stratify people who are low risk, who are very low risk versus high risk people, found that actually, if you use the algorithm, there were at least 8,000 potential PrEP candidates. And the point was not that all these individuals should get PrEP, but that you could use the electronic health record to create prompts to say to the clinician, this is somebody you should talk to about PrEP. And the question is, do those prompts work? And any of you who are involved in clinical care, you know that electronic health records now, providers get all kinds of prompts all the time. And there's something called prompt fatigue. So we can't assume that just because you're saying to a provider, gee, you should talk to your patient about PrEP, it might be useful. So there's actually a randomized trial now that Doug and Julia Marcus conducting with colleagues I mentioned. One of the database networks we're involved with, Advance. Those colleagues are based in Portland, and they're looking at 12 community health centers, and they're randomized to community health centers where prompts are being used now based on this algorithm or not. So we'll see whether at a population level this kind of information can be useful to inform clinical behavior and uptake. And the last point about PrEP, and I'm talking to some colleagues here at the center today, there's a real tension right now in the PrEP field because one mantra is we should demedicalize PrEP. The drugs are well tolerated and we really want to have an impact on the epidemic. On the other hand, HIV is a medical event. The medicines are well tolerated, but not 100% well tolerated. And PrEP is an opportunity to talk about other health issues, much in the same way that when young women come in for family planning conversations, their blood pressure might be checked. I might pick up hypertension or other health issues. So with Julia Marcus, we looked at Fenway patients, those who had PrEP indications but weren't receiving PrEP, and those who were receiving PrEP. We found that people who were receiving PrEP were more likely to be vaccinated for flu, have been screened for tobacco, have been screened for depression, as well as glucose testing. So this suggests, this may be self-selection bias. These may be people who are more vigilant about their healthcare, but it also may speak to that this is an opportunity for people to be more engaging in the healthcare system. And then as my last segue, I just want to show you this very busy slide because, PrEP and treatment as prevention are not the end all and be all. We have to think about increasing HIV and bacterial STI testing as well. And obviously there are different components, interventions we have to develop for enhancing engagement in care and maintenance in care. but we have to address all these different pieces of the puzzle. And the last piece of the puzzle I want to talk about are SDIs. So more than a decade ago, looking at our data, because we've had an electronic health record at Fenway since late 1990s, we're able to sort of look at our longitudinal patterns. And no surprise to anybody in the room, but we found that in the decade after the access to highly active antiretroviral therapy, and this is before the full implementation or the increasing implementation of PrEP, we're already seeing an increase in the rise of SDIs. So obviously a concern. We actually looked at our, it's not clean data because this is people coming in for clinical care. The window between visits is going to be funky, but trying to adjust for that, we did find that our incidence rates were exceedingly high. If you can see for chlamydia, gonorrhea, and syphilis. For any SDI at 24.8 per 100 person years, we realized we had a problem. So one of the things we felt once the data came out on doxycycline for prophylaxis, we thought we probably should be thinking about doxy-PEP. So one of the first things we did, Michael Traeger, who some of you may have run across, who's back in Melbourne, but did a postdoc here in the Longwood area. We used our Fenway data to say, what would be the most efficient strategy for providing the doxy-PEP? And you can see that there are trade-offs. If you basically put in the water supply, the number needed to treat is somewhat higher. You get to probably one of the more efficient numbers needed to treat if you just offer doxy-PEP to anybody with a prior STI in our population, but it's a little bit lower than you get fewer people. You're providing less doxy-PEP, but you're also reaching fewer people. So the sweet spot, certainly at least for all people with HIV and all PrEP users with this schema. So then we proceeded to do a lot of provider education. We created some shortcuts in the electronic health record to help pre-populate notes so that provider taking away some of the extra burden for providers for the provision of doxy-PEP. And these are our data and really started getting implemented in 2022. And you can see just the curve just shooting up over the year. So within the first year, more than 1,700 doxy-PEP starts. We reached about a little over a third of people diagnosed with a bacterial STI, a large number of people on PrEP, a smaller number of people living with HIV. And that makes sense because the population of people living with HIV tend to skew older and older as people are living longer. So they may not be engaging in as much behavior that may warrant the use of doxy-PEP. We compared the people diagnosed with a bacterial STI who did and did not start doxy-PEP. But interestingly, we found that doxy-PEP users tend to be older, less likely to be Hispanic, Latino, and more likely to be privately insured. So this may be speaking towards some level of disparity by socioeconomics and maybe race, ethnicity as well. And they were more likely to be PrEP users. But we didn't see race or HIV status necessarily being a major factor. In terms of trying to say, are we starting to see a population level impact of doxy-PEP on the community? Certainly, over the course of the year, we certainly saw a decrease in the rate of new chlamydia diagnoses, not an appreciable increase in gonorrhea, no surprise. And we didn't see an immediate impact on syphilis, so going in the right direction. So some suggestion that there may be an ecological impact. And again, these are not clean data because it's an open cohort. People come in and out of care, pass away, et cetera. So it's not all the same people, but starting to see some suggestion of maybe the beginning of a population level impact. So I want to wind down, leave some time for discussion, and just mention two other disease epidemics very briefly. And again, getting back to this theme of community health centers and population health. So because we had been funded by the NIH to do HIV prevention trials, studies of PrEP and other modalities, just like colleagues at the Brigham were funded to do vaccine trials and therapeutic trials, and MGH similarly, and the BI focus on vaccine trials. all 4 of the sites of these NIH networks, we were mobilized, and we were the sites for New England for what was called Operation Warp Speed. And you randomly assigned one of the vaccines. We were assigned to study the AstraZeneca vaccine, but enrolled, I think, something over 500 participants in the study. So it just speaks to the fungibility of research infrastructure for addressing acute emergent diseases, and the fact that community organizations can step up to the plate as well as other organizations. The other thing is that there are some new emerging infections that have particular propensities for different populations. And for us, it was Mpox. So we were the first site in New England to be sort of offering the Mpox vaccine routinely, and set up mass community vaccination clinics stationed at bars and other community events in order to increase community immunity when Mpox epidemic presented itself several years ago. So just in conclusion, hopefully there was a method to the madness in this talk today. And one of the key points I wanted to make was that sexual gender minority people are distinctive populations. Their specific health disparities and inequities, unique health needs. So speaks to the need for sort of focus and attention to them as a population. Community health centers can provide a wide range of services for diverse populations, and some centers may focus on specific populations. And community health centers can provide opportunities to analyze trends in population health, particularly certain communicable diseases. And then lastly, I think hopefully show that academic community partnerships can provide unique opportunities to address major health issues concerning population health. Just want to thank some of my colleagues, and thank you, and happy to take your questions. Yeah.
This is great, and thank you for taking us through both the history of Fenway, which has been remarkable as a force in understanding HIV and STIs, and some of the work you've been doing recently. If I could ask about that question, I have for you that I really liked Michael's work in thinking about how to best target and being informed by people's recent history. That's going to change as doxypep is effective. Right? You're going to see reductions in media, reductions in symptoms. As those go down further and further, is there a point where we would want to stop doxypep? Or is that something that's going to continue forever? If it is something that we think about stopping, how? What would be a strategy to think about? Is this something one can roll back if it's successful in bringing down rates of disease, and at what point do we say it's been successful enough?
Yeah, no, that's a fantastic question, which I don't think I have immediate, definitive answer to, because I really haven't thought it through. But I think it's a really worthwhile thing for us to think about. My bias is that less is more, and that I'd love to see a time where we don't have to use doxypep, or that we could have better community surveillance, so we could say we could cut back in this population this time, because as an infectious disease physician, and we're all painfully aware of that the microbiome is a real entity and individual in community health. It's nice not to create additional selection pressures, and there's always the concern about the unintended consequences of what superbug, even if it's not super GC, what else we might be selecting for, because there's certainly concern about there's been concern about various streptococci. There's MRSA concerns as well. So we can't, but again, the counter is that we think about all the tetracyclines used in animal feed. Is doxycycline a drop in the bucket or not? So I think this is part of the need why it's such a horrible time we're living through, because what a more enlightened administration would be saying we should be setting up more sentinel surveillance so that we understand what are the population level impacts. And it's hard. Those kinds of supports are hard to come by in the current era, but that's what we really need. But I think the idea of declaring victory and moving on has a lot of appeal, but with the caveat I would say is that it would only make sense in the context where you'd have the kind of ongoing rigorous surveillance, so you could know when things are starting to roar back and how they're going to roar back. And and as we were talking earlier, with some of the new medications for gonorrhea, that may change the environment too. I mean, are we going to get a better handle on gonorrhea, or is it just again further progress towards the superbug? So I think we need more data points to be sure, but I think it's a great thing to, and I think that's an important thing in general around some of these preventive approaches is that there's no need to hold them on, hold on to them forever. It's more to say in the context of where we are now, how do we use these agents? How do we deploy them as best as possible? And knowing that we all are dealing with, fragmentary information, but that's why we have to keep doing the research and talking to each other and learning from each other. Yes.
Hi, thank you for this talk. It was so fantastic. I'm a student who is also studying LGBT health, and I'm really interested in community engaged research, which I saw that you mentioned a bit. But I was just wondering, like, in working with these marginalized populations, to what extent is community feedback and engagement playing a role in your research?
No, thank you. Very much so. So there's formal and informal ways. So Fenway has several community advisory boards. So there's one community advisory board that's more about the health center part. So it's about patient care and sort of commenting, whether all the necessary services are being provided and in the most culturally responsive way. But we have a separate community advisory board for the research that meets on a monthly basis and tries to have a diversity of points of view. But then a number of the investigators for various grants will have either formal community advisory board or have community content expertise. So one of the networks I mentioned that we're involved in, the Adolescent Trials Network, has subject matter data experts, and so it's basically having youth, and every protocol has one or more youth members on who are not formal researchers per se, but are youth to inform the protocols, and then for some specific population studies there'll be separate caps. So, for example, somebody who's a graduate of the program here, who is on faculty at Harvard but now is at University of Michigan, Sarah Reisner, his work focuses on transgender people and particularly more recently on trans men, and all of his projects will have a transgender community advisory process is embedded into the protocol. So I can't say that every single person has a consistent level of community engagement, but it's pretty common and definitely considered part of the norm. And then several of the NIH networks that we're part of have community groups that advise on each of the protocols, and their community members on each of the protocol teams. So the studies that have the HPTN logo will all have at least one person who's a member of the protocol team who's from the community.
Thank you.
Yeah.
I have a question. It's kind of going on from our conversation that we had at lunch, but given the advancements in PrEP that you presented on the slide, as well as what the kind of racial demographic of people who are acquiring HIV in the United States, the racial demographic, and this historic distrust that Black people and other people of color have with the medical system, what are your thoughts about kind of meeting the new advancements in like the lenacapavir with this historic mistrust, especially around vaccine uptake and things like that? How has the Institute been able to address this or look into it just so we don't, expand that PrEP paradox that's already kind of going on?
Yeah, I know. It's really important point. Again, it's a very fraught time we're living through. So I mentioned the one study we'd been involved in, HPTN-073, which tried to develop a culturally tailored PrEP intervention for Black heterosexual men, and that was based on earlier work that we did that actually here in Boston we enrolled 700 Black heterosexual men and had a staff that were mainly Black heterosexual men, and really had a very community engaged process. So the frustrating thing is when you do these studies, studies over, there's no funds so to necessarily keep the work going. So the HB 073 was supposed to spin off into a study that was actually going to be a community randomized trial of sort of like a kitchen sink approach, recognizing that there are a lot of reasons why Black MSM, particularly in the southern United States, are not accessing PrEP. So some of it's medical mistrust, some of it's that the providers are judgmental and not providing welcoming environments, or not informed, or that the providers are in very red states and they don't have healthcare systems that are supporting wider access. So the study was looking at working at each of those levels, trying to address the different barriers, and it was initially cut by the administration to go forward. Now it's sort of like on life support where there's a pilot project going forward, which is not as robust as we'd like to see. But part of it is partnership. So Fenway, there's some diversity in our staff, but it's not a majority minority staff, and people want trusted information from people from the community who are more relatable. So a lot of the things that we do in Boston specifically, we do in conjunction with the Multicultural AIDS Coalition. And I don't know if you're familiar with them, but if you're interested in local work, they do incredible work. They're down, their main office now are Nubian Square, but they have programs that focus on young Black MSM, but also programs that focus on young cisgender women. They have several culturally focused programs for the diversity of the African diaspora in Boston. So they have some programs for people from East Africa focused, some programs that are more focused for people from the Caribbean. So it's also important to be aware of the sort of the nuances of the different cultural diversity in the different communities. Yeah, sure. Yes.
Thanks very much. I'm curious how your patient and participant population are kind of responding to the events of 2025 and what their kind of main concerns are, what their responses have been when you kind of see that academic environment that you're with.
It's been all over the map. I think many people feel fairly traumatized. I mean, I feel fairly traumatized, but so I think we definitely there's definitely at least a couple of people who have withdrawn permission to participate in studies because they don't trust how the data are being used. Like you're asking me, because when we're doing PrEP studies, we're saying like, what to do with whom, with what, and they're saying I don't want that. Even if I'm signing informed consent, that you're guaranteeing confidentiality. That how can I trust that with this administration? So we've had people leave studies. Fortunately, that's been fairly uncommon, and there have been people who, there've been on various issues. People look to the health service saying, "Why aren't you speaking out more? Why aren't you, being more proactive?" And health center is really walking this tightrope because health center, part of the ability of health centers to provide safety net services for people with inability to pay is because they get various kinds of federal grants, and so they want to be proactive enough to be advocates for the community, but also not get to the point where they become scapegoated by the community, because feeling like in the long run that's going to mean that people will have more services denied. So it's a very, very difficult time. Yeah.
I'm just going to build off that question a little bit. At one point, you mentioned that PrEP prescription gives an opportunity for a provider to have a conversation with a patient that could lead to interventions and other kind of health information being shared. But as patients have less trust in the medical system or don't want to give up information about their sexuality under the current administration, or if you live in a red state like I come from, where it's just not talked about, very rural areas, it's a totally different climate than Boston. How are you thinking about maybe changing, like at what point can we start advocating for patients to be able to access these prescriptions over the counter on their own without provider contact? Love to hear your thoughts.
Yeah, no, it's a great question. And two of the people I mentioned here, Doug Cracker and Julia Marcus, actually have an NIH grant. And again, it's an R21, so the duration is too short for the it's escape notice, but what was initially terminated as part of the Harvard terminations, but it did get reinstated. So they're doing a study of like interviewing providers and interviewing patients about attitudes about over-the-counter PrEP. And the two things, to my mind, the two things don't have to be mutually exclusive. But that's my personality. If it's choice A or B, I'll say I'll take A and B. But which not always the best for parsimonious thinking. But I think if we all think that PrEP is generally a good thing, there are always going to be these anxieties about people who are in the process of seroconverting when they start PrEP. But that's still going to be rare. So I don't think we want to limit it. We want to try to do as much as we can with community education. But on the other hand, I think we want to still make sure providers are trained and create welcoming spaces and have informed providers so that we can take advantage of PrEP as the educable moment and as an opportunity for more engagement in healthcare. But I wouldn't want to say you can only get this. We don't want to create so many barriers that people don't access it at all. So I think it's trying a variety of things, but trying to always get in the message to people. But please keep in mind that you want to be tested regularly for HIV. You don't want to be on this medication alone if you've become infected. Please keep in mind that if you're a PrEP candidate, you want to get screened on some regular basis for other sexually transmitted infections. It's part of a broader sexual health package. So it's trying to get all those messages across to people, but meeting people where they are and giving them the opportunity to access it. It's being studied now. There's some protocols studying it in putting in vending machines, for example, and certainly some great examples. South Africa colleague Linda Gale Becker's the Tutu Tester, the Desmond Tutu Health Foundation has a mobile van and goes around and into the townships and makes PrEP accessible to people. Mm-hmm.